So, yes, malignancy after transplant is a problem. Well, what do we do about it? The keys to what we need to do, we need to be knowledgeable about what cancers we need to look out for, what's our risk, how we can mitigate or lessen that risk. We need to educate ourselves and others about it, and that's a part of why we're here this evening. Screening is the key. We haven't figured out that magic bullet that's going to just pop it in your mouth and the cancer is going to go away. So we need to know that it exists. So screening is a big part of what we do to prevent dying from cancer. And a lot of the research that we do goes into screening. Can we come up with better protocols so that people know when they have cancer so that we can treat them sooner? So there are all these guidelines about how we screen for cancer given a heart transplant, and this is all written on cancer.org. And Penn has something that's a little bit simpler and is more aggressive than what's recommended. So, for example, for breast cancer, mammogram starting at 40. For skin cancer, everybody goes to a dermatologist annually. For cervical cancer, everybody sees an OB/GYN person annually. Colonoscopy for regular people, it's 7 to 10 years. For transplant people, it's 1 to 5 years based on what we found on your initial colonoscopy. Annually, men get a prostate exam and a PSA drawn. And then for lung cancer, which is one of the ones it's really important, we have actually changed what we do. Before we just did chest x-rays every year, and now we are actually doing chest CAT scans on people who we think are high risk. And those high-risk people are the people over the age of 60, if you've had a heavy smoking history or if you've had a history of lung cancer. All of those people get screened that way. Screening is the basis of our figuring out how to deal with cancers.
Just one comment
Sure.
on it, if I may. I think it's very important what you're saying in terms of when a transplant doctor looks at you. This is what they're recommending. You go to your local family doctor or go to a specialist in some other area, they're saying, oh, you don't need that. And you got to speak for yourself and say, no, wait, you don't understand. I'm a transplant recipient. We're at high risk for this. And so what do I have to do more than that?
Agreed.
And like the PSA, the advice I got originally, this was 6 years out from transplant. There was some higher PSA. Oh, it's slow growing. You're not going to have to worry about it. I said, no, you don't seem to understand. And I found out the gold standard was biopsy, and not comfortable, but it's done. And after a couple of those, they did find it, and it was radiated. And I'm now 10 years out, or what are we now? 15 years out from that, and it hasn't been a concern. But again, that was a very highly regarded urologist who said, you don't need that. So be very careful that you're talking to somebody who knows transplant, is my point.
Right, I agree, absolutely agree with you. So when things go wrong, when something's not quite right, the doc in the box on the corner, care first or going into the CVS, doc of the day kind of thing, probably not the right thing to do.